really. So you all should know the pathology behind rheumatic fever. That is the group B hemolytic streptococcus upper respiratory tract infection. That is going to cause the ultimately that is going to cause the manifestations of rheumatic fever. Okay, so then we need to know the diagnosis of rheumatic fever, how to be certain about the findings. So the first, like, what is the criteria? So in the criteria, we need to have this major criteria and minor criteria. So the major criteria has 5 things along with the evidence of preceding streptococcal infections. So like you need to have 2 major and or 1 major and 2 minor. That is the main criteria. So you have the criteria. So preceding evidence of preceding streptococcal infection, 2 major or 1 major and 2 minor. Right. So, but if someone gets it in Korea, then they don't really need to have any of this evidence for preceding streptococcal infection. And also, like Korea and these rheumatic fever manifestations, they don't come together because then Korea is occurrence around like after like it has a sort of a latent period. So if Korea and these sort of rheumatic fever manifestations were to occur at the same time, it is more suggestive of SLE than rheumatic fever. So for the features of major criteria, those are listed here. So carditis, polyarthritis, erythema marginatum, subcutaneous nodules, and silenium chorea. Those are the main 5 category criteria for in the major criteria. In the minor criteria, we have fever, elevated ESR, CRP, prolonged PR interval, and arthralgia. This is for the minor criteria, right? So this is how you can diagnose rheumatic fever. So these criteria can be asked in the MCQ, like they can give a history of a patient, and then they can ask like what is the diagnosis, and then they might ask why did you say so. So in that, if the question is such that you can tell I said it because the patient fits into the rheumatic fever diagnostic criteria, and the diagnosis of the criteria of rheumatic fever is this scalar. You can tell the entire criteria. So because the PAED paper SCQ marking is a bit tough, it's better to write everything like the entire diagnostic criteria, even if you think that it is not relevant. And in this 3 minor criteria, that is also there, but it's not really thing for concern, right? Okay, and then you need to know the recurrence of rheumatic fever is again high in these high risk populations, and when indolent carditis is the only manifestations, like 2 patients, like when patients present about months later, you don't need the criteria, right? And recurrence, you might not meet the criteria, and when there are like patients present months later with indolent carditis, again you don't need this, and chorea also you don't need. But basically, like we go by the chorea only, right? Sorry. Okay, right. Then you need to know the general measures that is important in this management of this patient. So when the patient comes, the management of the patient needs certain measures, obviously. So first of all, the patient has to be admitted, and for about minimum of 2 weeks, right? On admission, we should do an echocardiogram on the patient to check the cardiac involvement, and the patient should be having strict bed rest for 2 weeks, right? And then only at the end of 2 weeks, again, the repeat echocardiogram has to be done to rule out any cardiac involvement, and then only the patient can be discharged. So in the middle, the patient might develop cardiac involvement, and that can also progress to heart failure. In that case, the management is going to differ from the normal routine management. So they should have strict bed rest, and their monitoring should involve a sleeping heart rate. So the sleeping heart rate is important because that is one of the main thing to identify worsening heart failure, right? Because when the mitral valve is affected, like in chordae tendineae rupture, they can lead to pulmonary edema, and then they can also get heart failure. So the sleeping heart rate monitoring is the one that is very important. But the other thing is this patient might be having might be taking strict bed rest, but you need to think that the patient will also be having arthritis, like migratory arthritis, migrating polyarthritis. Therefore, the patient needs physiotherapy while the patient is in the bed as well. So, apart from the bed rest and the admission for 2 weeks, you need to know the investigations and the other monitoring that is important, like blood pressure, temperature monitoring every 6 hourly, and if there is fever, you can give antipyretics. And monitoring the input output is also important. One thing is to maintain hydration, and other thing, if the patient develops heart failure, again, that is very important to prevent fluid overload. Right? And also these patients will be receiving high doses of aspirin. Again, salicylate is going to cause fluid retention in the patients. So because of these three reasons, it is vital to put in the input and output of the patients. Right. The other investigations that you need to order would be the full blood count, because usually they will have a neutrophil leukocytosis, and a thrombocytosis will also be there in these patients. ESR, CRP, again, that were present at the minor diagnostic criteria of rheumatic fever, and you will also need to do the echo, as I mentioned earlier, and ECG, because again the PR interval monitoring is a minor diagnostic criteria. And in order to find evidence of preceding streptococcal throat infection, you need to do a throat swab for culture, but most of the time, by this time, the bacteria is gone, so you will get a negative result with the culture. But you can you always with the rapid antigen test, but you can do ASOT and check the T-tests. So apart from these things, when it comes to specific management, you will also need to do give them penicillin antibiotics. So because the group A streptococcus is universally sensitive to penicillin, so this is basically given to eradicate the upper respiratory tract infection. But if there is an hypersensitivity to penicillin, you can give erythromycin instead of penicillin. So along with the penicillin, like you can give the penicillin either through the IM route or oral route. IM, you can give it in the form of benzathine penicillin, right? But the other thing is the oral phenoxymethyl penicillin. So if the patient is having heart failure, you can give the patient is there like request to share the note? Hello? 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 Can you hear me? Hello? Hello? Can you hear me?
Chamod, this we can hear you.
ඇහෙනවා නේද? මේ අර නෝට් එක මගේ ලින්ක් එකේ තියෙනවා. මම මේ ඒක නැත්තම් මම ඒකට අපෝ දාන්නම්. කවුරු හරි ඉල්ලලා තියෙනවා තීක්ෂණ. ඊට පස්සේ මේක දෙන්න පුළුවන් අපිට either through IM or oral route. If the patient is having heart failure, අපි prefer to give the oral route, because මේක ලොකු needle එකක් 18 gauge large bore needle, and it's a knee IM, and that's very painful injection, and the child will even stay prone. Because of this reason, we prefer to give them oral if the patient is having heart failure. Okay. Then the other important things in the management will be the other thing is so one thing is penicillin, other thing is important monitoring, investigations, and strict bed rest. And doing the echocardiogram is important. And the other most important thing in the management is the aspirin and the other steroid supplementation to the patient. So they don't have any effect on valvular damage, right? You need to know that. But aspirin is an anti-inflammatory agent. So aspirin is they are given to me because there's a whole lot of serosal inflammation that is happening. So aspirin is given mainly for this anti-inflammatory effect. But also with aspirin there is sodium and water retention because it's a salicylate, and also it is going to cause the peripheral vasodilatation that is going to reduce the afterload, and also it is going to increase the basal metabolic rate. So because of all these reasons, the cardiac output is going to increase. So that is going to worsen the heart failure. What we do is, like, if the patient shows any symptoms of heart failure, then we switch from aspirin to steroids, right? So again, this is also their action. Aspirin is going to cause a metabolic acidosis and worsening. So, and if you start the patient on steroids, we need to taper it down over the 2 weeks period, and while you are going to add aspirin to the patient, right? So, so basically, the patient management of patient who is sick would be doing the investigations, bed rest, and monitoring with sleep in heart rate, blood pressure, input output, temperature charts, and giving medications, mainly the penicillin coverage and aspirin and steroids. Right. Then, apart from this, you also need to know a little bit about the pathology. So I mentioned about the infection with group A streptococcal and a type 2 hypersensitivity reaction. And also in rheumatic carditis, it is almost always it's a pancarditis that is going to involve the endocardium, myocardium, and pericardium. And in the myocardium, you have this classical ash of bodies. So ash of bodies, it is pathognomonic in rheumatic fever, right? So endocarditis will manifest in the form of valvulitis. Pericarditis will have a pericardial rub or effusion, and myocarditis will have this tachycardia out of proportion to the fever, right? So that is the other thing about the pathology, right? Then we also need to know about, I mentioned about doing the echocardiogram. So echocardiogram is important to look at each of these surface. You need to know in detail about the echocardiogram findings and all, right? Other thing is, they can ask questions on what are the types of murmurs that you can hear in patients with rheumatic fever. So one murmur is because rheumatic fever mostly affects the mitral valve. They will get a pansystolic, the mitral regurgitation murmur, the pansystolic murmur with axillary radiation, and this there will be muffled S1. So those are the features of mitral regurgitation murmur. Also, they can get an aortic regurgitation murmur, that is an early diastolic murmur, best heard in the left lower sternal edge when the patient is inclined forward and breath held in expiration. And the other pathognomonic murmur that you need to know is the Carey-Coombs murmur, right? So Carey-Coombs murmur, like you can time the carditis with Carey-Coombs murmur. This is a mid-diastolic murmur. So similar to mitral stenosis murmur, again it's a mid-diastolic murmur. But here it is also heard in the apex, but in mitral stenosis you get the opening snap, which is absent in here, this one. And also in mitral stenosis, then this one is very loud, but here the muffled S1 is there, right? So Carey-Coombs murmur is produced because of increased blood regurgitation from left ventricle to left atrium. This was questioned once in an MCQ. That's why I'm telling these things. So blood regurgitation from left ventricle to left atrium in the diastole. This is the mechanism through which Carey-Coombs murmur was has occurred in the patients. Other murmur is Austin-Flint murmur. So if they ask for 3 murmurs, you better write mitral regurgitation, aortic regurgitation, and Carey-Coombs murmur. If there are so 4, you can include this Austin-Flint murmur. Also, Austin-Flint murmur will occur because of this severe aortic regurgitation, because of which the mitral valve opening is also impaired, because there is increased blood volume in left ventricle, right? And you should know how you are going to differentiate the Austin-Flint murmur from the aortic regurgitation. So here the Austin-Flint murmur, obviously, like it is going to be sort of a bit of an early mid-diastolic murmur, but aortic regurgitation is going to be an early diastolic murmur. That is the other difference, and I have written a few side notes also. You are read if you are. I have shared this document. I will cross check it again. Right, and the other thing they will ask, this will be asked especially in the long case, like if you get a long case only, like they will ask what are the things that you're going to monitor in the patient in the clinic, like the follow-up, right? And what are the things that you will monitor in the patient in the daily ward round. So daily ward round, the same monitoring will be done, the general well-being and QHT, sleeping, pulse rate, blood pressure, input, output, those are the things that you will need to monitor. And the other, you repeat in the investigations as needed, you have to take, including the ECG and 2D echo, right? Those are things that need to be repeated. So once this patient is discharged from the hospital and then return to the clinic, right? In the clinic follow-up, what are the other things that you need to do? So one thing is, if the child, so you need to continue the penicillin prophylaxis. So this is how the penicillin prophylaxis should be continued in patients with rheumatic fever. So usually we bring down the patient every 3 weeks, right? And if the patient does not have carditis, you can continue in the penicillin prophylaxis for 5 years or until 21 years, whichever the longer. With carditis, but without residual valvular effect, you continue for 10 years or until 21 years, whichever the longer. And with carditis and persistent valvular lesions, you need to continue for 40 years and sometimes even lifelong. Right? And they should be advised about the dental hygiene and infective endocarditis prophylaxis if they have residual cardiac manifestations. And also, if the child develops an atrial fibrillation at any point, you need to start them on anticoagulation. Right? And serial 2D echocardiograms has to be done, but that has to be decided. So you can write just repeating the 2D echo, right? And yeah, so those are the main things that needs to be done with the clinic visit. So I discussed about the basic pathology of rheumatic fever, which is a hypersensitivity reaction, type 2 hypersensitivity reaction to streptococcal. So group A streptococcal upper respiratory tract infection that is going to cause like damage to both the heart as well as the joints, and the other things are also involved, like the skin, like erythema marginatum, subcutaneous nodules. Also, all these things will also occur in these patients, right? But we mainly discussed about the cardiac manifestations because that is going to be questioned in the MCQs, right? So we discussed how you are going to confirm the diagnosis of rheumatic fever, and then we discussed about the basic management that is to be done in the ward, and what are the things that need to be checked in the ward down, and how to do a monthly clinic follow-up of such patient, right? So I have written the other things also about the ash of bodies. You can initially read, and how to elicit sydenham yes, I don't think they will question. Okay, I will share this note. Right. Yeah, I will share this. Okay, let's go to the question. Carditis in acute rheumatic fever is evidenced by diastolic murmur, like Kericum's murmur is a diastolic murmur, so that is true. And then we have dyspnea. Obviously, if they go into heart failure, they will get dyspnea. And then it is also true. High ESR is also again true because that's a bit fit into minor criteria. Hypertension is a bit questionable. I would say better not to mark it, right? So it is not. It is not really a feature that you get in rheumatic fever. So I would say better not to mark. And irregular pulse, obviously you can get in rheumatic fever because any mitral valve pathologies can give rise to atrial fibrillation and irregular pulse. So the second question is not clear to me. I don't know about that question. So the second question, I think like better cut it off, like because this here they say 28-month-old premature baby. So I think it has to be 28-day-old. And again, apart from this heart rate, like heart rate is also like neonates have this heart rate and blood pressure. There's something wrong in this question, right? I couldn't find it. So better leave that one. So the next one is, we'll go to the next question. 2-day-old boy admitted to peripheral hospital with poor feeding. On examination, he is dyspneic. Respiratory rate is 80. Pulse rate is 170, right? And blood pressure in the upper limb is 80, lower limb is 55/30. So there you can see a blood pressure discrepancy, and saturation is 94. So here you have a patient with it's a straightforward coarctation of aorta. So this patient already has developed the because the immediate management, because the coarctation, the ductus arteriosus closes after birth. So that is the problem in this that we are encountering at the moment. So for the immediate management, you need to give IV prostaglandins. So I will take you all through the ductus arteriosus. So ductus arteriosus, like it is like usually ductus arteriosus is something that is going to close soon after birth, but like 1 month after the delivery, if it is not going to close, that is going to be the main problem, right? So ductus arteriosus, there is a neonatal type, like ductus arteriosus. There are two types mainly. Like there's an adult type ductus arteriosus and this other ductus arteriosus, which we like learn under this duct dependent circulation. So duct dependent circulation, ductus arteriosus causes severe manifestations that, but in the other variety does not cause that much of critical manifestations. So in those patients, they will get a continuous murmur beneath the left clavicle, like those things. Sorry. So this is not ductus arteriosus. I want to search for coarctation of aorta. Sorry, that's wait. Sorry. Okay, I can't find a coarctation here. Coarctation of aorta has two kinds, right? One thing is the adult type coarctation of aorta. Other one is the neonatal coarctation of aorta. That is the important thing, because when the coarctation of aorta occurs in the neonates, right? So that will manifest as like that is the one falling into this duct dependent circulation, right? Wait, I can't really find it here. Come on. So the main manifestation of this, the immediate management of this patient would be to give IV prostaglandin. So then the ductus arteriosus can be maintained patent. So then it can be considered to urgent surgical repair. Right. Next question is also about rheumatic fever. So arthritis in large joint is a clinical manifestation. That is true. Chorea is in major criteria, not in minor criteria. So that is false. Neutrophil leukocytosis is seen. And phenoxymethyl-penicillin is the treatment of choice that we discussed. And corticosteroids you can give if there is heart failure. Right. So here the next question. It's a 10-month-old baby presented with episodic crying. Right, and on examination, the peripheries were warm, capillary refilling time was 2 seconds, heart rate was 230, and ECG was taken, and it was in sinus rhythm, but no PVS were identified. And what is the next management option? Right, so they are asking about the management of a simple supraventricular tachycardia, right? So supraventricular tachycardia, because there are no P waves, so most likely it can be a junctional tachycardia, but we don't need to know that. So just they are asking about the supraventricular tachycardia management. So this one I can share this also. So supraventricular tachycardia, there's an algorithm. You just need to know that. So regardless of whether there is any shock or not, you just give the vagal manövers. So after that, only the pathway depends whether there is any shock or not. So if there is shock after giving vagal maneuvers, you need to give them. So if there is shock after giving vagal maneuvers, you need to get the vascular access, and then you need to give them this DC cardioversion has to be done. Synchronized DC cardioversion has to be done, right? So if there is no shock, so the first line they usually go for adenosine, 100 microgram per kilogram, wait for 2 minutes, double the dose and give like 100, 200, and then give 300, right? So this is the main algorithm for management of supraventricular tachycardia, right? So here in the answers, they had given vagal maneuvers. So the only 2 vagal maneuvers listed here are the application of orbital pressure and phase compression with ice water filled in a glove. So out of these 2, orbital pressure application can cause trauma, like it is a bit traumatic to the baby. It can cause damage. So therefore, we don't do that. Is the answer for this question, right? And this question I couldn't find the one properly. I have seen the same question, and they had mentioned about a supraventricular tachycardia after giving aminophylline. So again, out of the options that was given at that time, so they took again, like they took the same Weigel maneuver was taken as the answer. I can't really remember that thing because the explanation that they had given was aminophylline. Aminophylline is a drug that we give for to control asthma in emergency, but aminophylline has a long T-half. Therefore, even in such condition, even if you stop the aminophylline infusion, like you need to stop with the aminophylline infusion, that is correct. But even if you stop the aminophylline infusion, that there is no reassurance that the tachycardia is going to get reversed, right? So in that case, you need to give them some DC cardioversion, right? Okay. Now the next question. A 6-week-old baby boy presented with difficulty in feeding and dyspnea. Due to feeding difficulty, he was fed with express breast milk during the past week. On examination, he was found to have cold clammy peripheries. Pulse rate was 170, and there was bibasal crepitations. And liver was palpable 3 centimeters below the costal margin, and systolic murmur was heard on the left lower sternal edge. But next step in the management. So, so this baby is obviously in heart failure, right? So there's difficult heart failure. The other symptoms are difficulty feeding, dyspnea, right? Those are the main symptoms of heart failure, and they will have scalp sweating, right? Those are the main manifestations. And also this patient is having some form of a shock, right? Because cold clammy peripheries with a tachycardia. So then he seems to be in certain like a cardiogenic shock like thing. But bibasal crepitations are heard, right? Even though they have mentioned something about the shock here with the cold clammy peripheries and the tachycardia, the main focus of this question is about the breathing difficulty, right? Because they are emphasizing more on the breathing difficulty. So your entire management should focus more on the breathing difficulty. So the next step in the management, I think you have to be more focused on the answer that is going to relieve the breathing difficulty of the patient. So if you administer IV normal saline to this patient on top of the persisting existing shortness of breath, that is going to get worse. So here IV furosemide is the ideal thing because that is going to cause diuresis. So it is a diuretic. So diuresis is going to take time. I agree, but the main action, the main way that IV furosemide is going to help our patient is by pulmonary venodilatation. It is a potent pulmonary venodilator. So through that, it is going to relieve the shortness of breath, but that is temporary. So, but later onwards, when the diuretic action kick in, then they can get rid of the additional fluid in that body, so that can help with the patient, right? Right. So because heart failure topic came here, pediatric heart failure management, I will tell. Okay, so right now, because this management of a patient with heart failure was given as an MCQ in 2017. Oh, sorry, I stopped it. Okay, so can you all see the screen? Okay, so I have shared this document, or I think I have shared this document also. If not, I'll share it. Right, so here the symptoms of heart failure: tachycardia, tachypnea, and tender hepatomegaly. Right, So this answer was given by Anuradha Madam. So heart failure patients, they can present with coexisting heart failure and like can be exacerbated with a chest infection. So after like a prodrome of illness, fever, cough, chest infection, and then they can come with heart failure exacerbation. Right. So they will have an audible murmur, tender hepatomegaly. So those things will favor heart failure. Right. So uh, and they will so mainly regarding the management, first of all you need to position the patient, prop up the patient. That has to be written. Even they are kids, you need to prop up the patient. So giving oxygen is a tricky thing in this pediatric population because it can cause desaturation, because oxygen is a potent pulmonary vasodilator, so that can increase the vasocongestion in the lungs, right? That can worsen the pulmonary edema and thereby the shortness of breath and also desaturate the patient. But you so that is tricky, and so according to the given scenario only you have to decide whether to give oxygen or not to the patient, right? So you need to connect the patient to the pulse oximetry and also the multi-para monitor and monitor the blood pressure, pulse rate, respiratory rate, and ECG, right? IV cannula has to be inserted and blood has to be taken to full blood count, CRP, VVG, and blood cultures, right? So blood cultures is important because this patient can have underlying infection. Therefore, you need to take blood cultures also. IV furosemide, as I mentioned earlier, and fluid restriction. We usually go for 2/3 maintenance in these patients, and IV antibiotics because you are suspected infection, and the urgent 2D echo, urgent cardiology referral is also important. And the other important question that they ask is, what are the broad aspects in the management of the patient with heart failure? You need to identify the etiology for the shortness of breath, because it can be the exacerbation of heart failure, it can be the chest infection, right? So providing the supportive care that includes the nutrition, feeding, right? So those things are also included here, and optimize the medical management and monitor for the other complications because they can desaturate very fast, right? So you need to monitor for the complications, and definitely long-term care has to be arranged, right? Right. So those are the main things. I will share this document. So to optimize the nutrition in this patient, so and if you get such patient in the long case, so and you optimizing the nutrition is important, and I will share this. Yeah, I will share this. Optimizing the nutrition is important, and these patients with heart failure, they have feeding difficulty. So because of that reason, they can't be fed for a long time, and also they can't be fed with large meals. So you need to feed them with like energy dense, like or caloric dense meals has to be given to these patients, right? So caloric dense food has to be given in a short period of time without exacerbating their symptoms, right? And you have to be cautious not to exacerbate their symptoms by feeding them, right? So let's go to the next question regarding ventricular septal defect. So that is the commonest congenital heart defect. You all can see the screen. Awesome. Okay. So it is the commonest congenital heart defect. That is true. Failure to thrive is a mode of presentation. That is also true. Pulmonary plethora is a radiological feature. That is also true. And risk of recurrence is increasing in subsequent siblings. Well, I am not really sure about this. So if you get a question statement like this, because and in the Google also some say it does, some say it doesn't. So better not to mark a question statement like this. And majority is managed by surgery. That is false. So you need to have an idea about the VSD, CSD, and PDA. Yeah, we have it. Okay, so we'll start with ASD. So ASD, there are two types of ASD, ostium secundum and ostium primum. Ostium secundum is the commonest one, right? So here the ostium secundum is where at the location of the foramen ORA, and then most of the patients with ASD, they are not symptomatic, but they can also present with recurrent chest infections, wheezing, and also with arrhythmias. So the main when auscultated findings in ASD will include a fixed split. They will have the fixed, widely fixed split is there. That happens because of the ASD. Usually the blood in the right ventricle, sorry, the left side of the heart, it develops here. Because of that, the right ventricular the cardiac output on the side of the right side cardiac output is going to be high. Now, as we know, when we breathe during inspiration, because of the negative intrathoracic pressure that is created, anyway, the thoracic drive is going to increase the venous return to the right side of the heart. Because of this reason, during inspiration, there is going to be a physiologic split. So when they have an ASD, this shunting of blood from left to right will continue to happen. Because of this reason, the right-sided cardiac output is going to be persistently high in both inspiration and expiration, right? Also, because of the increased blood flow through the pulmonary valve, they will get this ejection systolic murmur at the upper left sternal edge, right? Okay. ASD patient, large ASD, only they will require treatment. Otherwise, they don't require treatment. So treatment mainly it is if they need treatment, they will need a minimally invasive cardiac catheterization and device closure is the main treatment. Rarely they need surgery as well. Right. Then we have the VSD. So VSD, 30% of all cases, it is the most commonest congenital cardiac defect, right? So it is there in the ventricular septum. Again, there are two types. We have the perimembranous and the muscular VSD, right? So VSD is up to 3 millimeters only. They call it small. I don't think you need to know the figures, right? So the patients can be asymptomatic or they can be symptomatic patients. They can present with various clinical features like failure to thrive, features of heart failure, right? So they can present with those features, and you will get the pansystolic murmur and the left sternal edge. So like in mitral regurgitation, you will get the pansystolic murmur at the apex, and the first heart sound in mitral regurgitation is muffled first heart sound, but here then in VSDs the first heart sound is normal, right? Then so most of the time, especially if the VSD is there in the muscular ridge, that will close spontaneously, right? And the murmur will also disappear with time. But if it is a large VSD or if it is a perimembranous VSD, it is unlikely to close spontaneously. At those instances, they will need an intervention, right? So management-wise, interventional like device closure and surgery are the two options. And actually, surgery, if they were to perform the surgery, they should perform it around 3 to 6 months period, and that is also because to prevent this Eisenmenger. We don't. I will talk about Eisenmenger later. Right. Other thing is about the PDA. PDA was questioned in our paper, so I don't think it will come again in the repeat paper also. But therefore, I'm not going to teach you all, but to be on the safe side, I think it's better if you all can read about the PDA from this illustrated as well, right? So because it was questioned, I mainly focused on ASD and VSD, right? Then we'll go to the next one. Right. So this is a 3-year-old baby with tetralogy of Fallot, presented with a 2-day history of fever and vomiting. And on examination, she is drowsy and lower limb reflexes are exaggerated. And what is the most appropriate next step in the management? So this sort of a presentation is very classical, right? So fever and vomiting. so tetralogy of Fallot, patients with tetralogy of Fallot, they have a polycythemia. That is because of the cardiac hypoxia. There is a secondary increased erythropoietin, secondary like high amount of erythropoietin that is going to cause high amount of red blood cell production. So that is going to give rise to a secondary polycythemia, which is present in patients with cyanotic heart diseases, right? So therefore, anyway, their blood viscosity is higher than a normal baby. Also, on top of that, this child is having fever and vomiting. So because of the vomiting, they get dehydrated. So because of this reason, their polycythemia, the blood viscosity is going to get more and more, like it is going to increase, right? So therefore, they are more prone to thrombosis, right? So the most one of the most classical sign of like classical site of thrombosis is this. Uh, Right. Classical site of thrombosis is the transverse sinuses, like cerebral venous sinus. Out of those cerebral venous sinuses, the transverse sinus is the most classic site of thrombosis. Right. So this is a classic history of a child who has got the cerebral venous sinus thrombosis. So therefore, most appropriate next step, I would say it is to do a contrast enhanced CT of the brain so that you can see visualize the sinus, and there are certain signs like anti-delta sign and all. So those can be visualized and make the diagnosis, but CT is not given. They have to go for a full blood count out of the options that is given to check the level of the hematocrit, right? And then you can decide on the further management. Okay, any questions up to that? Okay, let's do the rest. So cardiological conditions are correctly matched. AST ejection systolic murmur I just discussed. They will get an ejection systolic murmur in the left upper sternal edge. Palpitations with mitral valve prolapse. Again, mitral valve involvement, any mitral valve pathology, they can give rise to many cardiac manifestations. Yes, palpitation can be a fleet sign. With aortic stenosis, usually they get hypotension because of the left ventricular outflow tract obstruction, right? Usually they get hypotension. Cyanosis with critical pulmonary stenosis, yes, that is a feature. When there is critical pulmonary stenosis, right ventricular cardiac output is reduced, thereby oxygenation of blood is reduced, so they get cyanosis. Recurrent pneumonia with mitral stenosis. They like, even though they don't get heart failure with mitral stenosis, they tend to get pulmonary edema because when there's mitral stenosis, the blood tends to collect more in the lungs, right? Because the pulmonary drainage is obliterated, so they can get recurrent pneumonia in mitral stenosis, but they don't get heart failure because there is the left ventricular volumes are going to be maintained at the normal level, right? So let's look at the next one. It's a 3-day-old baby who presents with a history of poor feeding and excessive crying, and she's pale and she has very low femoral pulse and hepatomegaly, and blood gas shows a metabolic acidosis, and newborn examination was normal. And what is the likely diagnosis? So before looking through this question, we'll look at this duct dependent circulations, right? So I will share this PDF also. So duct dependent circulations, we have two types. We have duct dependent systemic circulation and duct dependent pulmonary circulation. Duct dependent systemic circulation occurs like if there is a, when the duct is, if there is some pathology, right? But and the duct is the only way through which the rest of the body is like the entire body is receiving blood only through this duct, right? So that like when the duct is going to close, the blood supply to the body, entire body is going to get affected. So then it will result in the baby is going to get going to shock with the closure of this ductus arteriosus, right? So usually in the when there is duct dependent systemic circulation, what happens is the pre-ductal saturation is going to be normal because they will be getting oxygenated blood. Now here you can see, let's see this one, let's see this one. So now this is the duct, these are the pulmonary arteries, this is the aortic arch, right? So this duct is going to close, right? So now, like prior to the closure, the duct was the only way how the body was receiving blood, uh, how the body was receiving blood. Now when this duct is going to close, the systemic blood supply is going to get cut off, right? Therefore pre-ductal saturation, right? So the blood, the saturation that is measured in the right arm is going to be high than the right foot, right? So therefore, right upper limb and the head circulation is by the preductal circulation, but the others are by the postductal circulation. That is the duct dependent one. So when the PDA closures or the ductus closures, there will be a grey shocky baby, right? And whatever the rest of the blood will go into the lungs. There will be pulmonary flooding. So when there is pulmonary flooding, the right ventricle gets affected. Therefore, there will be obvious form of a heart failure, pulmonary edema, and ultimately the hepatic congestion will also occur because the IVC also get congested eventually, right? And in the other hand, is also going to get affected. Systemic circulation is also going to get affected. The baby will go into shock, organ dysfunction, and there will be poor femoral pulses will be there in this baby, right? Because of the poor perfusion, there will be a metabolic acidosis, right? So this sort of duct dependent systemic circulations will occur in patients with critical pre-ductal coarctation of aorta. So this is the type of coarctation of aorta that I was talking initially. This is the one, critical pre-ductal coarctation aorta, where you need to act fast, right? Otherwise, where you need to give them the prostaglandin infusion, and critical aortic stenosis, right? And interrupted aortic arch and hypoplastic left heart syndrome. So let's look at this question. The baby is having a low femoral pulse, hepatomegaly, and there is a metabolic acidosis. So she is having a duct dependent systemic circulation. So out of these abnormalities, the only duct dependent systemic circulation is hypoplastic left ventricle, right? So that is the hypoplastic left heart syndrome. Now let's talk about the duct dependent pulmonary circulation. Now, like in case of a tricuspid atresia, where the duct is the one that is maintaining blood supply. So the tricuspid valve is atretic, so there is no cardiac output from the right side of the heart. So the pulmonary arteries will be getting blood through the aorta, right? So when the duct is going to close, so what happens is when the duct is going to close, the pulmonary arteries will not be getting any blood supply, but therefore the oxygenation of the entire body is going to get affected, right? Therefore the entire going to be less than the normal. However, there won't be any postductal preductal difference in the saturation, right? So their baby is going to be blue cyanotic because the deoxygenated blood only will be circulating. Poor oxygenation and carbon dioxide washout is also going to get affected, right? But since the organs will be receiving blood, there won't be any hemodynamic shock, but the organs will suffer from hypoxia and hypercarbia, right? Therefore, because of the because there is the hypoxia, anyway they will get metabolic acidosis, and also there is carbon dioxide accumulation that is going to cause a respiratory acidosis and also a metabolic acidosis, right? Right. So then note, sorry, and they will not be getting any features of heart heart failure and hepatic congestion. Right. So, okay. Right. This is about the other thing you have to know about this total anomalous pulmonary venous drainage. So, total anomalous pulmonary venous drainage is totally different from these duct-dependent pulmonary circulations. Right. So, total anomalous pulmonary venous drainage. All these. This is the out of there are 3 types. The suprathoracic total anomalous pulmonary venous drainage is the commonest type. Right. So, there are. This is not a duct dependent circulation. So here this is the SVC, and the drainage from all, like both lungs, will be there to this SVC, right? So this is the other type, the intrathoracic one. That is we are mostly familiar with this particular diagram, where the pulmonary artery veins, like both of these, all 4 will be draining to the right side instead of the left side, right? So these are the openings. So we are mostly familiar with this diagram, but the commonest variety of variant of total anomalous pulmonary venous drainage is the suprathoracic variant, right? So and it gives rise to this classical figure of 8 appearance, right? And obstructed TAP PD is the pediatric emergency. There the patient will present with bursting of cyanosis, pulmonary congestion, right, respiratory distress. So that is other pediatric emergency, but the management, I don't think they will ask about the management. It's basically a stenting of the obstruction. I don't know anything beyond that, right? So you need to know about the duct-dependent pulmonary circulations, duct-dependent systemic circulations, and also the total anomalous pulmonary venous drainage as well. And the other thing is the tetralogy of Fallot, right? So here, this is Naveen Ayer's. It's available in his drive, but I can share, right? So tetralogy of Fallot usually. Right. So there are 4 anatomical abnormalities in tetralogy of Fallot. Main abnormality is the pulmonary stenosis. This is the main abnormality. So this pulmonary stenosis is not at the level of the valves. It is at the level of the infundibulum, right? A little bit below the valves, right? So because of this, the right side of the heart will have to do more work. That is going to cause a right ventricular hypertrophy. And also they will have an overriding aorta. So normally the aorta is situated over the left ventricle. But here the aorta is a bit shifted to this side, and it is placed over the ventricular septal defect instead of over this side, right? So that blood will from both the right and the left side will be entered with the aorta, and this is the VSD. So these are the main 4 abnormalities that you get in tetralogy of Fallot, right? So the associations of tetralogy of Fallot, you have to know the Down syndrome, and these velocardiofacial syndrome. Better remember the velocardiofacial syndrome, right? So, and clinically, these patients will have cyanosis, but the cyanosis is not that prominent at birth, right? Unless the pulmonary stenosis is very severe, right? With age, what happens is the right ventricular outward tract obstruction, like increasing in the sense that that is not like the infundibulal pulmonary stenosis is going to stay as it is. That is why it is going to, we say it is going to increase. Therefore, the cyanosis is going to increase, right? Right. Then, with regard to investigations, you will get a boot-shaped heart, and there will be pulmonary oligemia because of the pulmonary stenosis. There will be a pulmonary oligemia in these patients. Right. So, the management of these patients. Other thing you need to know with regard to the management of these patients are the management of the hypercyanotic spell, right? In cyanotic heart disease, you need to know the management of hypercyanotic spell, right? So what happens in hypercyanotic spell is, it is given here. So there is some trigger like a hot bath or sepsis or whatever that is. So there is some trigger. So because of that trigger, usually like we know anyway, there is a shunting of blood from right to left side. So because of the overriding aorta, the aorta is receiving blood from the right and the left side. So this particular instance, right? So because of the because of these triggers and crying and all those things, there will be an infundibulum muscle spasm, right? And also that is going to reduce the blood flow through to the lungs. Therefore, blood will have to go somewhere. So therefore, the shunting will increase at that point, right? Also, the systemic vascular resistance is going to reduce when they have a sepsis or vasodilating drugs, and even the hot baths and all those things is going to reduce the systemic vascular resistance. That is going to further facilitate the left ventricular cardiac output. That ultimately increase the right to left shunt, right? So therefore, the hypoxia is going to get worsened in these patients, right? So there are the acidosis, hypoxia, that is going to cause metabolic like bursting of acidosis, right? Metabolic acidosis will worsen, and also because there is increased CO2 retention, that is going to cause a respiratory acidosis, right? And because of this hypoxia, what happens is there will be a pulmonary vascular vasoconstriction, right? That is also going to further worsen the shunting as well, right? So, and because of this hypoxia, there will be increased respiratory effort and also increased systemic venous return. But whatever the blood that comes to the right side, because of the infundibulum muscle spasm, will go to the left side. Okay, so this will act as a vicious cycle. So, what are the things that you need to do to break this vicious cycle? So, one thing is you need to increase the systemic vascular resistance, right? So, to increase the systemic vascular resistance, you can place the child in the knee chest position, right? And other thing is, so when you place the child in the knee chest position, one thing is the vessels, the pelvic vessels, they get kinked, right? The artery and the vein both get kinked, so that is going to increase. And other thing is you have to open up the pulmonary vasculature. So as I mentioned earlier, oxygen is a potent pulmonary vasodilator, right? Therefore, you can administer 100% oxygen, and IV morphine is again a potent pulmonary vasodilator, and also IV fluid bolus can be given. Anyway, the fluids are going to increase the cardiac output, right, in both sides, so that those measures can be given. So apart from these, you can also give drugs like ibupropanol. So it is a peripheral vasoconstrictor, right, and also IV sodium bicarbonate. If for worsening metabolic acidosis, you can give IV sodium bicarbonate. So even after one episode of this hypercyanotic spell, you need to refer this child for urgent surgery. Of course, like if the surgery is not possible, at least the banding or the shunt placement can be done. Right. Right. Then other complication that these patients tend to develop is cerebral thrombosis. So cerebral thrombosis will occur, as I mentioned earlier, with the polycythemia, they tend to get cerebral thrombosis. And also, because of the right to left shunt, blood is going to bypass the lungs. Lungs will have the alveolar macrophages that is going to filter out the organisms. Therefore, these organisms will get into the blood. So organisms can escape the pulmonary bed, pulmonary filter, get into the blood and go into the cerebral vasculature and cause cerebral abscesses there, right? So cerebral thrombosis can cause strokes, and renal vein thrombosis is the other thing. And also they can get infective endocarditis because they are sort of organisms, right? So they can get infective endocarditis, and because also they have VSD, they have a blood shunt, blood jet is there from these all these jets can cause endocardial damages and also cause the infective endocarditis and arrhythmias, and also they can get failure to thrive as well. Right. So let's look at the next question. So it's a level girl, 1 week duration. On examination, she is dystic and the pulse rate of 130, 170. Heart sounds reduced in intensity with the gallop rhythm, and there's a pansystolic murmur heard at the apex. Which of the following is the most likely encountered in her history? Okay, now, so this patient, so like there are two cardiac conditions. Now, there's a pansystolic murmur heard at the apex radiating to the axilla. So we know this condition. So that is a mitral regurgitation murmur, right? That is one thing. And she's dysmic and pulse rate of 170. Most likely there's a form of a heart failure is going on. And the heart sounds are reduced in intensity, right? With a gallop rhythm. Gallop rhythm, it can lead to heart failure. But heart sound reduction in intensity, like we know S1 is reduced in mitral regurgitation, but heart sound reduction in intensity is mostly suggestive of pericardial effusion, right? So as I mentioned earlier, patients with rheumatic fever, they have pancreatitis. So here this patient has typical features of rheumatic fever. Pansystolic murmur, so this mitral regurgitation as a valvulitis, which is a manifestation of endocarditis, and myocarditis, that is going to give rise to the heart failure, and pericarditis, that is going to give rise to a pericardial effusion and thereby causing heart sounds with reduced intensity, right? So this patient, the most, because now once you work out and get this is a rheumatic fever, the likely thing encountered in the history is a history of tonsillitis 2 weeks ago, right? Okay, let's go to the next question. Congenital cardiac diseases that deteriorate with the ductus closure. I have discussed the theory part. So we'll move forward. So the answer is critical pulmonary stenosis, tetralogy of Fallot, no effect. Juxtaductal coarctation of aorta is the adult type coarctation of aorta that I was talking initially. I couldn't really find it in the book. Give me a minute. I will try to find it in the illustrated. Here it is. Right. So adult type coarctation of aorta. So it's not a duct dependent thing, right? So it is it gradually only becomes severe. So it is after the opening, right? So they can be asymptomatic. So they will have this blood pressure discrepancies in also like even in the critical one, and these both they will have blood pressure discrepancies. In addition, they will have this ejection systolic murmur, and these collaterals are heard with continuous murmurs that is heard in the back. And the classical sign like ejection systolic murmur you can miss. I don't think like unless you are very familiar with the continuous murmurs, you will not be able to hear the collaterals. But radiofemoral delay is the main important physical sign that you need to pay attention in these patients with adult type coarctation of aorta. Right, so chest X-ray, you will see the rib notching. So I don't have chest X-ray rib notching, right? So so that is about the adult type coarctation of aorta. Right, so again, total anomalous pulmonary investigation, it has nothing to do with the ductal closure, right? Okay, so right now here we have a neonate at term delivered vaginally, and all examination is normal except a saturation of right hand 94, 94 and right leg 93. That is the next step in the management. So again, I did not do this part. Right. So this is, I will share this document also. So this algorithm was taken from the neonatology guidelines, and it is a must for you to read this. And even Kasusa's recording, he's repeatedly telling you about this algorithm, right? So if there's oxygen saturation, like discrete oxygen saturation is between 90 to 94 in right hand and right foot, but the difference or the difference is more than 3%, right? So then the next step is to do the repeat the screening in 1 hour. So if the discrepancy is, if there is no discrepancy of 3% and the saturation is more than 95, you can just directly discharge the child. But or if the saturation is less than 90 in any limb, you can have this test is considered positive, right? If not, you need to follow this algorithm. You need to repeat it in 1 hour, right? And you need to follow the algorithm. Right. So you need to follow this algorithm. So I'm not going to read one by one the algorithm. So once you consider the algorithm, once you follow the algorithm, and once you determine and that it is a positive screen, right? So and you have to do the urgent echocardiogram, and management has to be done urgently. I will share this document also. Right. So here the answer is to repeat the test in 1 hour. Right. So we have a 5-year-old boy on routine investigation at MOH is found to have a pulse rate of 80. That is fine for a 5-year-old. Blood pressure 90/60. That is also okay. And cardiac murmur in the pulmonary area with a grade 2 ejection systolic murmur. So normal heart sounds, no other abnormalities. This is innocent murmur. Right, it's a flow murmur, innocent murmur, and there are certain characteristics that you need to know about a flow murmur. Wait, let me find it. Right. So here, here you have the. You can take a screenshot of this. Sorry. Right. So innocent murmur, you can take a screenshot. So the baby is asymptomatic. It's a soft blowing murmur. It is only systolic, and it is heard in the left sternal edge. And the heart sounds are normal. No parasternal heel thrill, no radiation. So these are the features of innocent murmur that you need to know, right? So this is a typical innocent murmur. So again, the same thing I have discussed, duct-dependent circulation causes, right? The duct-dependent systemic circulation. Hypoplastic left heart syndrome is a cause. Critical aortic stenosis is a cause. Pulmonary atresia is not. Tetralogy of Fallot is not. And preductal coarctation is again a cause of duct-dependent systemic circulation. Right. So here she's a 10-year-old girl being evaluated for hypertension. On examination, she was found to have a web neck, no sex characteristics, most probable cause for hypertension. So this is a baby with Turner syndrome, and as I mentioned earlier, that coarctation of aorta is the one that causes hypertension in the upper limbs. And so baby with Turner syndrome, they have coarctation of aorta, and that can cause hypertension in the upper limbs. Right? We will talk about the other features of Turner syndrome, but nephroblastoma is usually found in children less than 5 years. Again, both nephroblastoma and neuroblastoma. Neuroblastoma also causes hypertension, right? And renal artery stenosis, again, renal artery stenosis can cause hypertension. Okay, let's look at the features of Turner syndrome. Here we have Turner syndrome. Is diagnosed. So the commonest cardiac manifestation in Turner syndrome is a bicuspid aortic valve, right? So other features, you can memorize these features. Like I have a way, like from head to toe you can memorize. So usually there is nothing much in the face. So they have a low, but they have a posterior hairline is low, and they have the web neck, this patient, web neck, and then also don't forget this goiter, right? They tend to get a hypothyroidism associations. They are with syndrome here, as I can remember. Wait, let me check. Turner's Yeah, there is an association with hypothyroidism. So that's a common thing. So in the neck, you have two things. One thing is look at the goiter, look at the web neck, and look at the low posterior hairline. And then come to the arm. So they get the cubitus vagus in the arm. And then look at the nipples. Yeah, they get breast hypertelorism. So nipples are wide apart. And in the heart, they get three. One thing is, they have two. They have three. One thing is by aortic coarctation of the adult type coarctation of aorta, bicuspid aortic valve, and also hypoplastic left heart syndrome is also associated with Turner syndrome. And they have gonadal atrophy. And this pigmented DY is also seen in these patients with Turner syndrome. And they also get peripheral lymphedema that is present even at birth, right? And as a whole, these babies are having short stature. So this is a good diagram. Actually, you can take a screenshot and to remember all manifestations of Turner syndrome, right? So we have again, I discussed this question. It's the same question with heart failure where you will to give IV furosemide. So features of coarctation of aorta in neonate include, so coarctation of aorta in neonate, so this is not the adult type coarctation, sudden collapse at birth. So now it's like this. So collapse at birth, it's not going to happen. So even if it is like the duct dependent circulation, so they will wait, like they can stay until the duct closes, right? So therefore they won't collapse at birth. Diastolic murmur is not there anyway. Both murmurs are systolic or either continuous murmur, so that's wrong. Radiofemoral delay, yeah, that can occur even at like neonate. They can get radiofemoral delay. Blood pressure difference is there. Tender hepatomegaly, yes, if they develop heart failure, and then like worsening heart failure, they can get tender hepatomegaly. Also, because it is a duct dependent circulation, when the duct closes, again they can develop tender hepatomegaly as I mentioned previously. Right. So the next one is this our paper. This is our paper. Okay, so last question. So 6-month-old with moderate patent ductus arteriosus. It is a moderate patent ductus arteriosus, but the problem is left atria and the left ventricle is dilated. Right? So the baby is asymptomatic, good weight gain, all these things are there, but because the left atrium and the left ventricle is dilated, there is a risk that this baby is developing pulmonary hypertension. Because pulmonary hypertension, it has two stages, right? Initially, because of the initially this pulmonary hypertension can be reversible, but later on with time, their pulmonary vascular remodeling is going to occur, and then the pulmonary hypertension becomes irreversible, right? So that is the main threat that we find in this baby. So it's a 6-month-old baby with moderate PDA and left ventricle dilatation. You can suspect there is some form of pulmonary hypertension is also there in this baby, but the baby is asymptomatic, that all is there. So therefore, because of the chamber dilatation, the baby needs an intervention, right? So baby needs an intervention. So indomethacin can't be given at 6 months now, so that is out. So you can't give indomethacin at 6 months. That is given at for the neonates, right? But nowadays we don't give indomethacin. Also, the premature kids, they are receiving IV paracetamol, apart from indomethacin. Not indomethacin is not really practiced, right? It can be given, but not really practiced. So repeat echo in 6 months. I don't think it is ideal to wait, right, for another 6 months, given the fact that the baby has already developed some form of pulmonary hypertension. Therefore, the baby needs a closure, right? So usually, I am not like even in the question I wasn't sure. It is either A and B has to be taken as the answer, right? But because the baby is asymptomatic and good weight gain, urgent interventions are not really needed. That is the main reason I thought of eliminating surgical ligation. I don't know the answer that they took. Therefore, I selected percutaneous device fusion few months as my answer, but I'm not sure about the answer that they selected. Okay, so that is the end of it. Any questions that you need to ask? I will share these documents. Any questions to ask? Okay then. Okay, that's all from me. Okay, thank you. Bye. Good night.